All right, while everybody finishes that up, let me just tell you a little bit about our first speaker. First off, he's one of the true experts in NET, and when he comes on, I'm sure he'll correct me for telling everybody they have a NET when, well, I'll let him explain more about that. But he's got a tremendous background right now working with the Mayo Clinic. And he's a medical oncologist who he's really focused on NET. Not that that's the only disease he ever sees, but he's very focused on that. Interestingly, he handles a number of lung carcinoids as well. And his focus is primarily on neuroendocrine tumors, and he does quite a few clinical trials as well. So without further delay, please welcome Dr. Thor Halfdanarson from the Mayo Clinic in Rochester, Minnesota. Welcome.
Thank you very much. I hope you can hear me okay.
Yes, yes.
Perfect. So thank you very much for the kind introduction and for the invitation to speak. This is definitely something I really enjoy, is speaking with patients and caregivers with NETs. So let's just dive into it. So I think I can advance the slides. Yes, I can. So I just wanted to make sure that I'm in presentation mode. So these are my disclosures. I do quite a bit of research, and these are the objectives of the talk. That is the first of 4 of them. So I'm going to discuss what are neuroendocrine neoplasms, how common are they, what do we mean by grade and stage, how are grade 3 different, and then instead of the life expectancy question, which I don't think we'll have time to do, I'll talk a little bit about some of the sort of treatment strategies that we use for patients with neuroendocrine neoplasms. So what are neuroendocrine neoplasms, or NENS? So, well, are they not called NETs anymore? And I will refer to them as NENS for a few slides, but just NETs comes more natural to me, so I'll probably sort of go back to calling them NETs here as we get further into the talk. So let me just explain what NENS are. So NENS are neuroendocrine neoplasms, and I'll explain what the neoplasm is. And NETs stands for, or NETs, neuroendocrine tumors, and NECs, NEC, for neuroendocrine carcinoma, which is the most aggressive part of the NEN spectrum, or the NEN family. So a neoplasm really means an abnormal mass of tissue that results when cells are dividing or proliferating more than they should, and they don't respect the natural borders. They start pushing into other things, spreading to other organs, and they just don't behave as they should. So that's a neoplasm. Tumor is essentially the same definition, but for neuroendocrine neoplasms, tumor actually has a very special meaning, and we'll get into that in a little bit. So these are some of the terminology, and trust me, even oncologists find this terminology confusing. I find it confusing. So, but this is what we have to deal with. So let's talk about what they are. So these are malignancies, essentially cancers that can arise almost anywhere in the human body. So mostly in the small intestines, lungs, pancreas, and rectum. And they are extremely heterogeneous in the sense that it's almost as if no 2 NETs or NENs are the same. So they can be exceptionally aggressive in one person and can be exceptionally slow in another person, but yet they may look similar in the microscope and on the scans. So how common are these? So why are we having a full conference on NETs or NENs? There's certainly a good reason to do that. And because these are not uncommon cancers. So they are becoming more common, and we expect to have about 7 per 100,000 new diagnoses per year. So if I think about that as the town I live in, Rochester, Minnesota, we're about 100,000. So that means in Rochester alone, which is not a small, not a large city, we expect to see 7 cases per year, and half of them are from the intestinal tract. So most commonly, as I said, lung, small bowel, pancreas, rectum, and appendix. Let me then walk you through this graph there. So this is a graph. You can see 2 lines, a blue line and a yellow line. So the blue line is really the number of new cancer cases of any kind since the early 70s until 2012. And as you can see, sort of midpoint, there's a little peak. So cancer sort of hit the peak there in the early 80s or actually early 90s. And then cancers in general have been a little bit on the decline, probably mostly thanks to less smoking and better screening. And so these are all cancers. The yellow or the orange line that you can see, that has been going up pretty much since the mid-80s. These are the neuroendocrine tumors, obviously much, much less common than most other cancers. But as you can see, there's a steady increase. And I wanted to explain to you two concepts that we use in epidemiology a lot. And one is a concept called incidence, and that's the number of new cases over a certain period of time. And that's, for example, in the incidence in Rochester, Minnesota, would be expected to be about 7 per 100,000 per year. The prevalence is a different term. So the prevalence is actually the number of patients living with a cancer at a given time point. So even if the cancer is rare, if a lot of people live for it for a long time, at any given time, there will be a lot of survivors and people actively dealing with the cancer. So essentially the prevalence is how many are actually dealing with this problem today. So moving on, so let's take a look at the different subtypes here. So here you can see a lot of different curves, but all of them seem to be heading up. And so these are the number of new cases. And I just wanted to point to you the lung, that's the top blue line. So they have probably increased the most. And I think that's probably because of more scans being done. Then we can see the pancreas and the small intestine. So the pancreas is so those are the gray ones you can see sort of shooting up here. And then rectum and the small bowel. So all of these are actually going up, but very, very few of them are staying the same. So this is becoming more common. And why are they becoming more common? So what's going on? And so one thought is that we have better scans than we did in the 70s and 80s. That probably explains some of it. But then we're also scanning people more. So there are more CT scanners around, and we get CT scans today for reasons we wouldn't have done a CT scan 10 or 15 years ago. Let's say if you go to the emergency room with abdominal pain, you're probably much more likely to get a CT scan now than you were 15, 20 years ago. So we're picking up a lot of tumors where we're doing scans for other reasons. So these are called incidental diagnoses. And then I think both healthcare providers and patients and families are just becoming more aware of this. So they may have symptoms and they may go to their provider and say, this is what's going on, and I think this is what I may have, and can we do a scan or can we start a workup? But then even if you account for all those things, I think there's also a real increase in the incidence. And that is the biggest question. That's probably the most sort of a burning question in my mind. Why are these things becoming more common? So moving on, what causes NETs? So for most of them, especially for the small bowel NETs, we just don't know. And which is also very frustrating to me, because obviously patients and caregivers, they want to know what caused this, and we don't know. And so occasionally, actually quite rarely, small bowel neuroendocrine tumors run in families. We see that every now and again. And then there may be some environmental factors, smoking, alcohol have been implicated, but not in all studies. A recent study from Utah suggested possibly some environmental exposure. They were looking at people who lived in like mining regions, but that I think is all very sort of early data. We're not sure what to make of that, but there might be something in the environment, but we just don't know what it is. So the pancreatic NETs, they are much more likely to have a syndrome, a familial syndrome, most typically multiple endocrine neoplasia type 1 or MEN1, but then there are some other much less common diseases, von Hippel-Lindau, and some others that that can be associated with pancreatic NETs. And then oddly, so with the lung NETs, which are becoming more common, that's happening at the same time that the common lung cancer is getting less common. And we're smoking less, which is great, and but yet, with declining smoking, the number of lung NETs are going up, and we don't understand that. They don't seem to be that related to smoking. So let's talk a little bit about tumor grade and differentiation, two incredibly important terms. So we use the tumor grade and tumor differentiation to predict how well or how fast the tumors will behave. So the NETs can be super slow growing grade 1 tumors, and they may not change at all over the course of several years. I have a few patients I've never treated that just sit and watch the tumors and they don't grow, or they can be super fast growing. Those are the high-grade neuroendocrine carcinomas, and that's actually largely determined by the grade and the differentiation. This is by far the most complicated slide I have, and I will test you at this at the end. No, I'm kidding. I won't do that. So I just wanted to show you, this is the classification that we go by professionally now. So we have these grade 1, grade 2, grade 3 neuroendocrine tumors that are well differentiated. So the grade 1s are slowest growing, but none of them are like super fast growing. And then at the next two here, so grade 3 neuroendocrine carcinomas, they can be super fast growing. So I won't dwell on this much longer, but this is just what when I am documenting what I see in the clinic, I usually go by this table, but we'll try to keep it a little bit more simple than that. So what is tumor grade? So it's a system that predicts how fast cancers will grow and then spread. And what we do is that actually we take a piece of tissue, a little thin slice, we stain it with a particular stain that only sticks to cells that are actively growing, and then we count the number of those cells. And then if 99% of the cells are growing, it's a very aggressive tumor. If only 1% is growing, it's not aggressive tumor. So more dividing cells, more aggressive NETs. And this is how it looks like to the pathologist. So on the left-hand side, grade 1 tumor, you see that there's like a sea of little blue dots and occasional brown dots. The brown dots are the cells that are actually growing. And those are the less aggressive grade 1 tumors. On the other side, to the right there we have the grade 3 neuroendocrine tumors or neuroendocrine carcinomas. You can see that's a sea of brown dots. That means that almost all of the cells are actually actively growing, and those are much more aggressive tumors. So not all grade 3 neuroendocrine tumors are the same, or neuroendocrine neoplasms. Some of the grade 3 tumors are actually fairly slow growing, and they're called well-differentiated grade 3 neuroendocrine tumors, and they behave somewhat similar to the grade 2 tumors, probably a little bit more aggressive, a little bit faster growing, but not crazy fast growing. And then we have the poorly differentiated grade 3 neuroendocrine carcinomas that are much more aggressive, and that gets to the question of the differentiation. So what is tumor differentiation? So we talk about grade and differentiation, and these things are related, but they're not the same. So the differentiation is really how much the cells resemble the normal cells they started from. And does it look sort of like the normal cells, or do the cells look bizarre, different sizes and shapes? Do they look angry, as the pathologists sometimes say? And just by looking at this in the microscope without doing any particular stains, we can tell if it's a poorly differentiated tumor or if it's a well-differentiated tumor. But here we require a really good pathologist. All poorly differentiated tumors are high grade or grade 3. Not all grade 3 tumors are poorly differentiated. It's very important. So when you have a grade 3 tumor, it can be super aggressive or it can be not so aggressive. So stage is probably the most important determinant of prognosis. So tumors come in stage 0, 1, 2, 3, and 4. Stage 0 we rarely see in neuroendocrine tumors. And this is how it looks like. So stage 1 or 2, so the tumor is limited to the site of the origin. So in this particular slide there, it's actually for colon cancer. So that would be limited to the colon, but that would also apply to the pancreas or the small bowel. So limited to the organ it started in. Stage 3, the tumor has gone to lymph nodes, and that makes it a little bit more likely to come back after surgery. Stage 4 is that the tumors have left the organ they started in and gone to other organs, most commonly liver in neuroendocrine tumors, and sometimes lungs and bones, and even some other parts of occasionally brain. So what are the symptoms of neuroendocrine tumors? Well, the symptoms, as many of you know, can be, they can vary greatly from one person to another. And this diagnosis is often delayed because the symptoms can be non-specific. Someone is just feeling unwell, has a little diarrhea, maybe a little weight loss, or something is just off, but you just can't put your finger on it. And then healthcare providers, when you they may not realize that this might be a neuroendocrine tumor. And to their defense, let's say a general practitioner may see 3 or 4 people with abdominal complaints in a day, but that same person may diagnose less than 1 neuroendocrine tumor in the course of 10 years. So they're dealing with these symptoms all the time, but only a small part of the patients they're dealing with actually have something really alarming. So you have to be sort of keep all of your sort of antennas up and senses wide open, and because these are really tricky things to diagnose. So the tumor characteristics dictate the presentation. So slow-growing tumor, grade 1 tumors, tend to have a long course until they get diagnosed. Poorly differentiated tumors, fast-growing, typically a short history before you get diagnosed. So you were feeling fine in September, and October things were off. In November, you're just having a lot of symptoms. So that would be consistent with a more aggressive tumor. And then obviously the extent of the tumors and where they are. Let's say lots of tumors in the liver can cause abdominal fullness and pain. And then the functional status. So what is a functional status of a tumor? A functional status, where a functional neuroendocrine tumor is a tumor that makes chemicals that make you ill. And these can be, in the next slide, I'll show you some examples of that. So let's first talk about symptoms from the tumor itself. So that can be obstruction, let's say blockage of the bowel, causing crampy abdominal pain, nausea, vomiting, blockage of a bile duct, causing jaundice. We can see that with pancreatic neuroendocrine tumors, or for those who have lung neuroendocrine tumors, blockage of the airway, or the bronchus, those little tiny airways, and then beyond that blockage, you can have recurrent infections, and then these tumors can bleed. You can cough up blood. You can have blood in the stool, or the tumors can cause pain. Let's say if it's pushing on a nerve, or if it's in the bone, or in the liver. And occasionally, and I just saw a patient not too long ago who actually just felt something in the abdomen. Turned out to be a very large liver. And then non-specific symptoms, just like weight loss, feeling unwell. And so these can be very, very subtle. So the functional tumors are different, and they're quite fascinating. So for the small bowel neuroendocrine tumors, you can have carcinoid syndrome. So these are almost always from the small bowel, although they can happen with lung tumors and with ovarian tumors too. Flushing of the skin is often transient. Sometimes the patients won't notice because sometimes there is no sort of sensation of warmth. These are not hot flashes. It's just this like color change, typically face, upper chest, often brought on by alcohol, exercise. Someone gets really emotionally upset or angry or something. There's usually a trigger. Diarrhea, which can be very debilitating, up to 5, 10, 15 times a day, even more. Carcinoid heart disease, we won't talk about much, but these would be damage to the heart valves. And then carcinoid crisis, which thankfully is rare and seems to be less of an issue than it was before. And then the pancreatic tumors can cause a variety of symptoms by producing hormones. Let's say if they make a lot of insulin, you drop your blood sugar. If they make a lot of hormone called gastrin, you have a lot of stomach acid, and even to the point you get really bad reflux or diarrhea, and in the worst scenarios, you can actually have a perforation of your bowel. So this is from a Canadian medical journal, so used with permission from the journal there, and a person with skin flushing. You can see sort of the cheeks and the forehead, just very subtle. And sometimes you would look at this person and would say, well, this could just be sunburn. But then if this sort of comes and goes within the course of a few minutes, well, that wouldn't be sunburn. And so this is a very typical carcinoid flush. So how do we diagnose neuroendocrine tumors? Well, it's a tricky thing to do. So we need the good pathologist to look at the biopsy once we've obtained that. We need really good radiologists and nuclear medicine physicians. And then we may need other specialties: gastroenterology, clinical chemistry, pulmonary medicine, surgery, endocrinology. So it's a team effort to get to the diagnosis. And oftentimes requires more than one biopsy and multiple blood tests and urine tests. So why do we treat neuroendocrine tumors? Essentially, we treat to relieve symptoms, such as the carcinoid syndrome, and we treat to prolong the survival of patients. Essentially, we want all of our patients to live as long as they can with as good quality of life as possible for as long as possible. And be careful with the treatment, because the treatments have side effects, and sometimes the side effects are actually worse than the symptoms from the tumor. And then there can be what's called financial toxicity. Some of these treatments can be really expensive. So don't forget that each patient is unique. So we have to think about it in that way, that there's not like one size fits all here. So everyone's a little different, requires different approaches. So things to consider before starting therapy: do we really need the treatment? Sometimes we can just wait, or the tumor's growing fast, or there are troublesome symptoms. And then where did this start? Because the treatment is different for pancreatic neuroendocrine than it is for a small bowel neuroendocrine. And then what's the stage of the tumor and differentiation? These are all the things we take into consideration. So as for the treatment, so team approach is really the key. There's often no rush in starting the therapy. I would much rather get the diagnosis right and have a good plan before I start than rush into things and then later regret having started the wrong therapy. And so better to get experts in other specialties involved early if needed. And Tumor Board is incredibly important. So this is where we get a lot of people in a room, a lot of brain power, different specialties. We look at the scans and the pathology, and we try to come up with the best solution for that particular patient. So why Tumor Board? Well, more brains work better than fewer brains, and having multiple specialties early may change the initial approach. Medical oncologists like myself are terrible at deciding who should have surgery and when. And sometimes there are several different approaches, and then we can go back to the patient and say, well, this is what the surgeons thought, this is what the medical oncologist thought, and this may end up being fewer visits for the patients. Instead of having the patient see 4 different specialties, we can just do this all in Tumor Board. So treatment of symptoms. So this is my last 2 slides. So for functional syndrome, so like carcinoid syndrome, somatostatin analogs can be very effective in controlling the symptoms and can also control the tumor growth. And then other drugs like telotristat, everolimus, chemotherapy, PRT, surgery, liver embolization, we'll hear more about later. So a lot of different options, and what works for this person does not work for that person. So it's a very, very individualized therapy. And then in terms of controlling the tumor growth, somatostatin analogs, targeted therapy, like everolimus and sunitinib, possibly immunotherapy, we don't know where that fits in yet, chemotherapy for select cases, especially high-grade neuroendocrine tumors and pancreatic neuroendocrine tumors, and then what's called systemic radiation therapy, or PRRT, or Lutathera. And I think we won't go into that in more detail. These are all really great topics, but hopefully we can address some of that in questions later. So that brings me to the end of the talk, and so I think I will probably just sign off now and let the next speaker join.